I'm Tom Smith. Let me first apologize for medical oncologists everywhere, of which I am one, and also thank Amanda Kopenhaver. If you'll raise your hand, she's a medical student working with us at Hopkins this summer from Florida and gives me hope that the next generation will do better. And also thank Robin Matsuyama, one of the first postdocs I had at VCU, who's a real expert in health literacy. I don't have any relevant disclosures. I do have to say that I'm on the test writing committee for the American Board of Internal Medicine about hospice and palliative medicine, so I'm not allowed to discuss any answers or questions within the room, but I'll be available in the hallway afterwards. We should talk about communication, about prognosis. I'll show you some examples that we're not doing a good job of it. There's some barriers, but thankfully I think there are some ways to help us. Part of it is listening to the story that we just heard to tell us that we should do a lot better. Couple definitions. Literacy is the ability to read and write. You can measure readability by things like the standard simplified measure of gobbledygook, or the RAT, or the realm. You know, take your hospice brochures and ask what level of readability are they, and you'll find most of them are 6th grade or above. Different from health literacy, the degree to which an individual has a capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. It was 98 million in 2003. Robin and I couldn't find an updated number. I'm sure it's higher now. Part of the medical care is more complicated. And people who have poor health literacy have worse outcomes, more hospitalizations, lower compliance, higher mortality, less use of hospice. It's people who are older. It's black versus white, poor education versus better education, suburban versus rural, poor vision, comorbidities, all of those things. And this is important for palliative care because 10 randomized clinical trials now show absolutely no harm in any trial, better satisfaction, quality of life, symptom control, less depression and anxiety, even with more prognostic awareness. 4 show better survival, no increased cost in any trial. Tell me another branch of medicine that improves the quality of care, improves the quality of lived experience for people, and lowers cost. Increases hospice referral, which also increases survival and costs less, but it's only if you can access it. Jennifer Temmel's trial got everybody's attention. You know, she did a randomized trial of usual care versus usual care plus palliative care for newly diagnosed non-small cell lung cancer patients. It was 1 palliative care visit a month, and I'm often asked, well, what's the magic? And Betty Farrell and I came up with the acronym of TAME. It's time. It's about an hour a month by somebody. It's an extra hour a month. You have to do formal assessments for symptoms, spirituality, and psychosocial. You have to have management protocols, and you have to do education about prognosis, how are you coping, advanced directives, hospice is best care. You have to mention the H word, family coping, and start doing some work on legacy. It is not rocket science, but it has to be scripted. So, this is the improvement in prognostic awareness. Is my cancer curable? And the answer for all these patients was no. But if you had palliative care, there were very few people that remained inaccurate, and a lot more people were much more accurate if you spent that extra hour a month. And you had better quality of life, you had half the rate of depression, you had a little less anxiety and better mood. It changed end-of-life care so that more people had documentation about resuscitation preferences. It doubled the time in hospice, almost tripled the median time in hospice. And it reduced the use of IV chemotherapy. I'm a chemotherapist. I love giving chemotherapy when it works. But 3rd and 4th line lung cancer chemotherapy does not improve life, except if you're talking about pembrolizumab now. If you were on the palliative care group and had accurate perception, your chance of getting chemo in the last month of life was 9% versus 50% by her colleagues, 50%. And that's probably why the group that got the palliative care alongside usual care lived almost 3 months longer, 3 months. But that's not the only trial. This one was published the year before with 300 plus cancer patients at Dartmouth. And you'd want to be on this survival curve marked by the purple palliative care star If you stop the trial right there, the hazard ratio for death would be about 0.7, 30% less chance of dying. And we weren't surprised by this because we'd done the last big randomized pain device trial, giving meds into the spinal cord here, into the spinal fluid. And if you got your pain relieved, you lived 3 months longer. Not a surprise. And then Marie Bakaitis just published this in JCO with cancer patients, again, from upstate New Hampshire and Vermont. And if you got early palliative care, follow the palliative care purple star, you lived several months longer. And this is Betty Farrell's trial. This is just coming out about lung cancer at City of Hope. And if you had palliative care, 4 nurse practitioner visits, 4, count them, 4 visits, that's the rocket science, you lived substantially longer. But wait, it's not just cancer. This is Irene Higginson's data from dyspneic lung cancer patients at UK College London. And if you met with the palliative care team, look at the difference in survival. 30% chance less of dying, 30%. If this was a drug, we'd be down at the FDA demanding it. Current communication is not satisfactory. Only 17% of lung cancer patients could guess that their prognosis with stage 4 disease was less than 2 years, 17%. Most people thought that they could be cured. That's in sharp contrast to 80 to 90% of people actually wanting to know the prognosis, even if it's bad. Here it is graphically. Is it very likely or somewhat likely that you could be cured from your lung cancer by chemotherapy? 69%, 81% of colorectal cancer patients. None of these were associated with having an accurate or inaccurate response, race, education, functional status, patient's role. Associated with more accurate responses were care in an integrated network. So if you had a group that potentially worked together, you understood your prognosis better. And if you had lower scores for physician communication, if your physician was blunter with you, you understood better. Hispanic people, Black people, Asian American people were slightly more likely to have very inaccurate prognostic awareness. We don't know if that's who you are, who you're seeing as your doctor, what you're hearing, what you're being told, more likely some combination of all the above. And oncologists like me almost always tell patients that their disease is incurable, but we quickly follow that with, we'll convert it to a chronic disease. And we talk about the collusion between patients with a cancer and their physicians played a primary role with a quick transition by both physician and patient from discussion of prognosis to discussion of treatment options and schedule, and then it never comes up again for most patients. This just came out from Tim Pollack, the same data set. Do you think surgery would cure your stage 4 lung or colorectal cancer? And the answer shouldn't surprisingly be a whole bunch of people, like 75%, thought surgery would cure stage 4 disease. If you were female, a little bit less likely, unmarried, a little bit less likely to have inaccurate. African American and Asian American were more likely to be inaccurate. Education and income didn't play a role. I think I'll skip this one for time. It's just a video. It shows that you can do this, but with videos. If you have a talk about CPR, it doesn't change people's perception about it being effective and doesn't change people's choices. If you show people a 6-minute video about CPR, doesn't matter what your literacy level is, people get the video. The video says CPR usually doesn't work by a trusting physician. And people get that message. You can't get that message by having somebody talk to you. It's not just patients. African American Black physicians have very different views. It's not just education. Looking at Black physicians, 28% thought tube feeding was heroic. White physicians thought 58% thought it was. Black physicians were far more likely, if they had a persistent vegetative state for themselves, Black physicians were far more likely than white physicians to want CPR, being on a ventilator, have artificial feeding, which tells me a lot that it's resiliency, it's how you're brought up, It's how you've been excluded from healthcare. There's a whole bunch of messages here that it's not just education. You can't get good information from the internet either. This is just coming out in the Journal of Oncology Press. We looked at the American Cancer Society, cancer.gov, my own ASCO, American Society of Professional Cancer.net, and UpToDate, and at least one disease-specific website for stage 4 disease. Only 26 out of 50 had any notation of 5-year survival. Only 8% had any idea about average survival, what the average person could expect. And only about a quarter even mentioned that this was a serious or life-threatening disease. Most literacy, most hospice and palliative care material is not readable. Most is well above the recommended US 6th grade reading level. We have to revise that. Does communication make a difference? Absolutely. If you use a question prompt list, people ask more questions, and we're taking one into a handheld app now. If you use videos, it makes people choose better about end-of-life care. And if you do electronic prompts to the doctor, you increase the number of people with code status determination. And if you teach people about standard care, DNR orders in place of death, you can change the median time to DNR order from 12 days to 27 days, and you can reduce the hospital death rate by 51, it was 50% before, down to 19%. How many people here want to die in the hospital? How many people want to die in the ICU? Got to be somebody. No, okay. We're making decision aids. These are we made for our professional society. This is lung cancer before pembrolizumab. Your chance of third-line lung cancer helping you is close to 0. And you can do these. You can put them on the, you can hand them to patients. There's no chance of cure. You can give this information to people. You follow it with, hey, people use this time to do a life review, pass stuff on, spiritual issues, financial issues, family issues. Who do you want to make decisions for you? If your heart stopped breathing, would you want CPR? How do you want to spend your last days? Do you want to have hospice involved? And the interesting thing is, this does not take away people's hope. We actually measured people's hope before and after. It stayed exactly the same. In fact, it went up a little bit. So look for these decision aids like this for the 10 most common cancers, hopefully coming this fall to a television station near you. We're trying to teach oncologists to sort of do the reverse of the slide you showed, Diane, that identify people up here who need palliative care, and then don't wait till the end. Bring it up when the disease starts to grow, when the heart failure starts to get a little bit worse, when the diabetes starts to cause more vascular complications. And we're working with all our providers to get a temporary tattoo that goes on your forearm. What's your understanding of your situation? How do you like to get medical information? What's important to you? And Rebecca Kirsch's question, what are you hoping for? Have you thought about a time when you could be sicker? Should we think about a living will or an advance directive? Because people want to know the diagnosis, the natural history, the prognosis, symptoms, and what caused it. This is simple and easy to do. So prognosis and understanding of it is desired, and 80 to 90% of people want to know it. Makes a big difference. It really dictates how you get care. And I'm not about denying people care. There are some people who turn down second-line lung cancer chemotherapy because they don't think it works, when in fact it improves survival and it improves quality of life. Those are good things to know, and if you see it on a sheet of paper or watch a video about it, you can understand it and maybe choose better. I want people to get helpful chemo. I want people to get less unhelpful chemo, and that leads to more use of hospice, death at the desired place, less distress, and markedly less caregiver distress, probably longer survival. We need some rewards for doing this tough work. Medicare may introduce a payment for having these tough decisions as of yesterday. We're making better decision aids. We need prompts to remind us to do this, and the National Coalition for Cancer Survivors is funding a project for a handheld app. We need communication skills, and Bob Arnold's going to talk about this. Finally, it may be important to have somebody else do this. I don't think a lot of oncologists are wired this way. We're really not. And if I can ask Diane to do this for me, or ask Rob Razak, to do this for me. That makes a huge difference. All you need is somebody on the team to have these difficult conversations. Thank you.